I hope we're all live now. Hello to all of our online delegates. This is an opportunity for you to ask those burning questions for those of us who aren't in the room. My name's Jane Russell. I'm Communications Manager at Retina UK. I'm delighted to introduce Professor Julie Silvestri. She is Clinical Director for Ophthalmic Services at the Belfast Health and Social Care Trust, Honorary Professor at the Centre for Public Health at Queen's University Belfast, and co-lead for the Northern Ireland Clinical Research Network. Welcome, Julie, and thank you for joining us today.
Thank you very much, Jane. Can you hear me?
We can. So,
Fabulous.
Julie, could you tell us a little bit about yourself first, please?
Yeah. So do you want to show the slides? Because the slides are really about what I do, if that's okay. Yeah. So thank you very much, Jane, for inviting me. It's a real privilege. I have been dipping in and out today, and it's been wonderful. I'm sorry I'm not there in person, but maybe next year. So I'm consultant ophthalmic surgeon, ophthalmologist, and I've had a long interest really in genetic conditions of the retina, both the inherited retinal degenerations and macular degeneration. And I've been really passionate about genetic testing in the Northern Ireland population. Unfortunately, the funds are not like they are in England and Wales and some of the devolved nations. So we've had to do this differently, but I'm pleased to say due to the generosity of one of the pharmaceuticals, we've now been able to genetic test most people. And one of the real drivers was to try and find someone that we could treat with RP65 with Leber's congenital amaurosis. And unfortunately, we haven't found anyone. And then my other areas of interest are the genetics of macular degeneration and intraocular magnifiers, which are devices which go into the eye to try and help magnification of central vision. So this slide actually talks about why is genetic testing important, and it actually speaks to one of the questions, and I'm not going to talk for too long, so we'll get through the questions. And the question is, many people want to know the prognosis. When will I go blind? And it's very difficult just looking into an eye because a lot of retinitis pigmentosa looks much the same, but as was explained earlier, there are about over 300 genes that cause it. So we're now getting much better if people want to know, and that's the question I'd like to ask the audience. Do they really want to know? Because we are in a better position due to the genetics and also due to certain types of photographs that we can take in imaging, because we can now watch how things are changing. So I'm not sure, I tend not to offer that unless people ask specifically. I know my colleague in Dublin, David Keegan, they do give that out to everyone, but I always wondered how it was received and does everyone want to know? So I don't know, Jake, can we do a show hand? Who would like to know, and should we be more active about it or not? Do you think?
I'm not sure that we can
do that.
We can see that behind the scenes on the screen, unfortunately.
Oh, you can't do a hand.
Yeah, sadly.
A left hand, no. But maybe somebody can speak to that. And then the other good reason for having probably the genetic testing, if it's positive, is because it gives you an accurate inheritance pattern, and therefore you can get family counselling, accurate family counselling, which very often is different from what we thought it was. It used to be before the genetic testing, you're sort of guessing at an inheritance pattern, and sometimes you do get a bit of a surprise. And in some countries, not sure so much in the UK, but embryo selection is available for some types of conditions depending on their severity. Just next slide, and I think this just speaks to So the gene frequency, and one of the questions does mention that USH2A is probably one of the USH is one of the most common genes, and certainly in our population it ties with the ABCA4, the Stargardt's gene. And now that there's a big area in the blue which says 55%, but now we're down to 30% of patients that no matter what gene panel you do, you just can't quite get the answer, and there's work to be done there. Thank you. And then just the last one is just my work on big team. And people wonder, you know, why does it take so long? It is very complicated, and my patients have said to me, "You told me 20 years ago there'd be some treatment," you know, and it takes an army of people, from basic scientists to clinicians, help with patients, to actually move this forward. And as we heard earlier, the administrators, the FDA, you know, it is a long journey. And just the next one, just to very briefly. Yeah. So, and these are really more for the intraocular magnifiers, which go in either instead of the lens at cataract surgery or on top of the lens that has already been put in, and they do magnify central vision. Some are tricky, give very good magnification, but can be difficult to get used to, and some are a little easier, that at least if they don't cause give any improvement, they don't cause any problem. So that's I think that's happy to answer any questions in any of that. So can we move to the questions then?
Yes, absolutely. So if anybody online does have a question, please pop it in the Q&A box. Matt is behind the scenes. He's going to coordinate the questions. We have had a few questions in advance from our community, so I'm going to ask them, and hopefully Judy will be able to answer them. So first one, how close are we to having a treatment for RP?
Right. So, so I heard Michael Michaelides talking on this morning, and we do have, the thing to take encouragement from is we do have proof of principle. The treatment for the Leber's congenital amaurosis is gene therapy for RP, and it works really well. So the proof of principle is there. The difficulty is that some genes, from what I understand, that particular gene is easy-ish to work with. The USH2A and the ABCA4 are large. Now, so if you imagine, so all these genes they're put into the retina, under the retina, and they're carried in a virus. And if you imagine, a virus will only have a certain amount of capacity to bring information and so forth into the retina. USH2A and ABCA4 are very large genes, and this has really limited. But I was very pleased to hear quite recently through the avant-garde folk that, and maybe they've spoken this morning, but they've now sorted this, as has somebody else, so they can they're packaging it into 2 viral genes, putting them under the retina, the thing gets made, and then some zipping protein thing zips it up. It is quite amazing. Or I think there's another company who are making it and then zipping it together before it goes underneath. So I think that has been the rate limiting step in those 2 genes, which are very prevalent. So, and there are quite a number of trials who are in phase 2, some in phase 3. So I think, you know, I'm saying it shouldn't be too long, but I like Michael Michaelides thing. He took the cautious out of his optimism. I think he's now optimistic rather than cautiously optimistic. So I think we're definitely, and then there are the genes that are called gene agnostic, which means it doesn't matter which variant you have, which is great, especially for people who have a very rare variant, because let's be honest, gene therapy costs a lot to put to trial and so forth. So if you have a very rare variant, it will, you know, it might be difficult to get a specific, but then maybe we don't need one because we have these gene therapies that hopefully will be suitable for most. So I think it is looking encouraging. I wouldn't like to put a timeline on it though.
That leads actually quite well into a question we received online this afternoon, which is, I have choroideremia, but they cannot find the gene. Is there any progress in finding the gene? In the 2% that the gene cannot be found in the DNA. So presumably that really talks to what you just said about gene agnostic treatments.
Yes. So there's that, and it is very frustrating, you know, when you don't get the gene, and you know, and you think it, you know the diagnosis clinically. But so I think the way I heard a talk last week from a scientist saying they're approaching this by looking actually at the RNA and going backwards, looking at the changes in the RNA, which is a product that is made by the gene, makes DNA and then RNA. So they're looking at the changes on a protein structure and going the other way. so that even though they can't find the gene, apparently from this analysis of this RNA, they can work backwards from the protein to the DNA and so forth. So that's the first time I've heard that. So it does seem to be a new way of, because it's got to be there, but because they are genetic, but for some reason they are. So maybe it's a gene we haven't looked at, maybe it's in some odd place that's difficult to look at, but that did seem promising, and it does seem to be a new way forward. Yeah.
Okay, right. So next question. We have quite a lot of questions actually in advance.
Excellent.
I have maintained a healthy lifestyle, including regular exercise such as running, hill walking, and spin cycling. Is there any evidence that strenuous exercise, for example, heart rate over 175 beats per minute, or endurance over 2 hours, can be detrimental to or accelerate retinal conditions such as RP?
Thank you for that. And you'll be glad to know you stretched me to the point I had to go and look it up. Right? I had never heard of anything that would be detrimental. But when you go and look up strenuous exercise and detriment, what it says is that there's a marker in your blood called CRP, reactive protein, which is a marker of inflammation. So apparently if you do really strenuous, anybody do really strenuous exercise, it puts it up, which can cause inflammation. However, if you do it consistently, it's a lowering overall, it's a lowering of inflammation. So if you're doing it, or if you're just doing it once and then give up, that you might take a bit of a hit. But it's not specific to RP, but if you're doing it consistently, it seems to lower your inflammatory response, which, and there is evidence that in retinitis pigmentosa there may be some elements of inflammation. So overall, it's a good thing, and certainly should keep you living longer anyway.
Absolutely. And this next question, which has come in by text from Matt, so I'm not quite sure where it's come from, but is really relevant actually. Are there any known risks to people's sight with the use of the new weight loss drugs? Now that might be something you need to look up again, so we may need to get back to
no. I do know this, and I know it for a different reason, because I do treat a lot of diabetic patients, and there is some threat to sight, but it's due to optic neuropathy. It seems to be that the optic nerve can get inflamed and people can suffer loss from that. And I have heard some patients saying that, but mainly at the higher doses. And I have looked this up for a patient, and there is a small risk, but it's probably like 1%. It's not huge, but there is a small risk to sight, but not to the retina, but it is to the optic nerve, which can be quite profound if it happens. Yeah.
Okay, no, that's really interesting.
Yeah.
Right.
And I don't know if it's more common if you're not diabetic, actually. If you're taking it and you're not diabetic and
right.
taking it for weight loss, maybe slightly higher risk. Yeah.
Okay, yeah, so that, for our community, they could, of course, fall into the diabetic category, but some very much would be considering using it for purely for weight loss. So yeah, I think that's something probably to speak to your own ophthalmologist about if you're considering starting a weight loss treatment, or certainly your GP. Right, here we go, moving on. So my son is 13 years old and has XLRP. Currently, he's most affected by night blindness. Would any of the prospective treatments currently being tested restore or improve night vision, even in those who have never had functioning night vision?
Thank you for the question. So the X-linked RP was a fairly early focus for gene therapy. It's been a bit slow, and I believe that's because there's some parts in the gene that are a bit tricky to work on, but there are some treatments that are in phase 2, moving to phase 3. But to answer the question, I would believe that it would be helpful, and the reason I say that is because in the Leber's congenital amaurosis, which has been treated, there are some fabulous videos online where you can see a child, a 2-year-old, cycling along, can't do it at all in the dim light, and then after treatment cycling about very happily. So hopefully it should. And then there's a recent trial going on at the moment, myosin 7A, which is for Usher's 1B, and very early. It's not hasn't reported yet or anything, but they are showing improvements in seeing the chart, the visual chart under low luminance conditions. So in slightly darker, so it does seem to improve night vision as well. So I'd be encouraged with that. And you know, some of the trials have failed, but they have, you know, and patients would say, but how could it have failed? I could do stuff after the treatment that I couldn't before. And what actually happened, and maybe somebody's been over this, trials need to set endpoints before they start. Otherwise, nobody's going to pay for it. And I think the endpoints were set too high. You know, and you know, you look in retrospect, and I think John Marshall mentioned this, you know, maybe some of the endpoints. But now I think we've all learned a lesson. Avril Daly, she's president of Retina International, very keen on trying to help the FDA and the European Medical Agency to try and understand that there need to be other, you know, endpoints that make it a success, you know. So yeah.
There was a little bit about those endpoints in the most recent edition of Look Forward, our newsletter. So the autumn edition, it talked about the latest results from clinical trials and why they haven't been considered to be successful. So if you're interested and you haven't already read that, it is available on the website. We have it in audio, plain text, and accessible PDF. So you know, go and have a look. Right, okay, next question. Lots of questions. So
yes,
any updated information on Stargardt disease?
Yes, so Stargardt is the focus. Again, it's one of those genes that's very big, but avant-garde, and somebody else has got over that, I think. So at the moment, and I felt not so bad when I heard that Michael Michaelides was having trouble getting this trial thing through Moorfields, you know. It's just, you know, we've been trying to, so for Stargardt's, there is a natural history study called Stella, and it's recruiting people to see how things progress with a certain level of vision, and that will feed into Celeste, which is a treatment trial. Now, it's not a gene therapy trial, it's more a medicine that can, you know, reduce the transport of vitamin A into the retina. So there is that, and then they are also working on gene therapy as well, but it has been slow, indeed, probably for those reasons, really. The other thing about Stargardt, there's a thing called the hypomorphic allele, which is a bad gene, but not too bad. Okay, it's kind of not bad. So if you have a bad gene and this hypomorphic allele, the progression isn't just as bad, and that's why there's sometimes a bit of variation in the progression of it.
Okay.
Yes. So hopefully there should be something, you know, soon for that.
Right, I'm going to grab one of the online questions now. So, is there any progress with optogenetics?
Now that is something I don't know a lot about, but I think they are working hard on it, and that's where they're introducing cells to make cells that are no longer functioning detect light. And it from what I was reading, it does seem to be so. Injecting cells that have never detected light or have kind of stopped, they inject this opsin, which makes them sensitive to light, and then they start making signal, which apparently the brain seems to be able to take up quite well. So I think it's relatively new, but it does seem to be moving quite well, and would be suitable for people who have on the poorer end of the spectrum in terms of vision. But I haven't been involved myself, really.
No, that does sound encouraging. So I think you've slightly covered this, but it would be really good to hear if there have been any recent developments in stem cell therapy, as it seems to have gone quiet since early positive results were reported some years ago.
Yes, it does seem to have gone quiet, and I think it is quite tricky. So it depends which part of the eye. So it's really good for the cornea on the front of the eye. It's much more simple and it works well for, so if you get an injury to around where the cornea meets the white part of the eye, the limbus, then the cornea goes cloudy and transplanting of cells into that area, that works well. But that is a much simpler thing. The cornea is not as complicated, obviously, as the retina. So they are still working hard, but it is slow. It is slow, and I noticed that I think it was Michael Ladies or that didn't say much about it either. It does seem to be taking some time, I think, because of the complexity. Might work better in macular degeneration, because I've heard that they can put a little scaffold. It's more limited to one layer of the retina, the retinal pigment epithelium, which is out at the end. It doesn't interfere with all the visual sort of pathways. So I think the best success has been actually putting in a scaffold into the retinal pigment epithelium. That seems to be slightly more promising because it is slightly simpler. But I think for the IRDs, I think it is going to be difficult. Yeah.
So actually this leads really nicely on to the next question, which is where do you see research developing in the future? So there's obviously lots of different research pathways being developed or have been worked on, seem to be moving forward very quickly, and then like with the stem cell therapy, it's gone a bit quiet. So where do you think where do you think the most promising research is going to be in the future, I think is probably the better question.
Yeah, so I think for the genes that are quite prevalent, like the USH2A and the ABCA4 gene specific, they're getting on well there, and I'm confident that will come quite quickly. And then the gene agnostic treatments where there's one in phase 3, that's where the treatment will work really for any variant or where you don't have a variant. And it's called the Limelight trial, and it's phase 3, and it's really to try, and it should be able to treat a very large population of patients with RP, regardless of their specific causative agent. And it uses a gene called NR2E3, which does actually in itself cause RP, but it's very rare. And there has been a trial which has 2 arms, 75 participants in each arm, and one arm had people who had the rhodopsin gene, and the other just had people with any variant. And they're hoping to conclude and apply maybe for regulatory submissions in 2026. So it must be going quite well already in phase 3 and planning hopefully to apply. So I think that would be just fantastic, because it would work for pretty much everybody. I mean, I
So
think
is this trial in the US or is it over in this country?
So it's called OCU400 Limelight. Sponsor Ocugen. I'm not sure where it is. I haven't heard anyone, I think. Oh, here, John Hopkins, National Eye Institute.
Okay.
Yeah. So I thought that's, yeah. Sorry.
So we'll as our delegates will know, Kate Arkle, our research development manager, is often putting together content for us. So we will look into that phase 3 trial and see what we can find, and share some information in our next newsletters.
Yeah. So they started dosing patients in mid-2024 and are on track for regulatory sort of submissions in 26. I think that would just be fabulous.
Absolutely.
I mean, so there's that, and then I think for the patients who are maybe further along their journey, the up to the ones where they're putting in the lights to the cells that will improve the light submission should also be helpful and should advance quite quickly.
Okay, still got more questions to come. So my diagnosis is non-syndromic retinitis pigmentosa caused by recessive mutations in the USH2A gene, which I understand is the single most common genetic cause of RP. Given how many people are affected, is USH2A currently a major focus for therapeutic development? If so, which approaches seem most promising? And if not, can you help us understand the main barriers for developing effective treatments for this gene? And I think we've talked a little bit about this already,
Yes.
and the pharmaceutical companies certainly mentioned this earlier. But yeah, if there's anything you'd like to add, please do.
So, I mean, the Usher syndrome, there are a few trials for the Ush type 1, and they're proceeding. For the USH2A, I think the size of the gene had been a limiting factor, but it does now seem to be moving. Also, I think there was one trial that failed. I think it was QPR, and it failed on endpoints, and that was the one the patients were saying, but actually I could see better. And now I read this morning that actually that has been taken forward by another company, and hopefully looking at different endpoints. So I think it will have to be either, well, unless one of these gene agnostic treatments might help as well.
Yeah.
I mean, yeah, that would get over kind of all that as well. And then I don't really know much. I think there's a question on J-site, on the retinal progenitor cells, that whether, you know, that would be something, but that is usually for people who have are on the lower end of visual acuity, rather than, because you would imagine if the treatments start to work, we need to get these in early, you know, and once they're safe, you know. And now, you know, for the Liebers, you know, babies are being treated at the age of 1, you know. So once you're happy with the safety, then soon you've got the gene, and, you know, even get one eye treated, you know, once the safety trials have been done.
Yeah, the Luxturna treatment has been incredible for many, and I remember we interviewed Jake Turnant, who was the very first person to receive the treatment in the UK, and I remember vividly him telling me that he loves football, and being able to watch a football match. He can't see the detail, but he can see enough to be able to feel like he's watching a match rather than just listening to the audio, which was incredible and fantastic to hear.
I
Right.
have a funny story, but maybe I shouldn't
Oh,
tell
no,
it.
no,
Anyway.
do tell.
So someone, not in this country, not in the UK, somebody treated a 65-year-old granny with Leber's congenital amaurosis, right? And usually it works better earlier on when your retina's kind of, but anyway, she did quite well, and apparently she looked in the mirror and she'd never seen herself. And she looked in the mirror and said, I'm much wider than I thought I was. Right? She had no mental image, right? So she went on a diet. Now she's a completely different lady, and can see she did reasonably well. But I thought that was
Oh,
amazing.
lovely.
Yeah.
Excellent. Okay, right. We've got a few more questions. So, can you give us any update on the J-cell clinical trial in the USA? And do you know what the participation criteria are roughly?
Indeed, and I'd like to make a shout out to Cecilia, who will know who she is, and she's been interested in this, one of my patients. So one of your team very kindly sent me the inclusion criteria, and I have looked it up. I looked it up before, and it looked to be that there wasn't a trial open, but it is now open June, I think, of this year. There were 2 previous trials by J-site on these progenitor cells, which are like stem cells, and they go into the retina. The first one, they dosed so many patients, and then the second part of that is they went back and redosed. But this is a new trial, and started in June, and I think has gone on for a couple of years. So yes, the clinical criteria, I mean, there's a whole page of them here, but basically evidence of clinical diagnosis of RP supported by electrophysiology, and I don't think that's going to be difficult to sort of to establish for most people. Age, older than 18, less than 60. And the vision criteria, which I guess is what people really want to know, between 1 and 55 letters, with not more of a difference of 15 letters between one eye. So I think the eyes need to be sort of fairly similar. So you can't have one eye with 1 letter and one eye with 55. They have to be within 15 of each other. Now, I don't know how people test this. The ability to fixate with the study eye at least 75% of the time. And that, I suppose, it needs to be done on one of those visual field machines. You can look at a target on microperimetry. So that's something probably, if you were interested, somebody would need to do for you. And a central island of field in the study eye of 8 degrees it's small, but it could put some people out, and then the rest are just willingness to participate and so forth. So yeah, so there would be a few parameters that your ophthalmologist can give you some of those very easily, and possibly even the visual field, but you'd have to have the tracking holding fixation for 75%. So yeah. So that's
Okay, I'm not sure whether we've kind of covered this, but actually it's still worth asking, I think. So when RP is first diagnosed, it would be really helpful to the patient to be given some idea of how the disease might progress. And I one of the speakers earlier in the day did mention this. Is there any research being done on predicting the timescale / development of the disease?
Yes. So I did touch on this, and now there is, because if I know the variant, there's a lot of data online that you can go and look at the specific variant, and this will tell you this patient is likely to be legally blind by whatever number of years. I get asked it occasionally, but it's more people who've been, who have progressed along. Most people, when they just get their diagnosis, don't really ask that, which I think is, and I don't volunteer it, and funny, I had a patient come back to me the other day saying, oh, when I was first diagnosed, the consultant, which was years ago now, the consultant said, you'll be blind by the age of 20, must have been an X-linked RP or something. And, the patient said, that I can still see, and I'm 45 now, still reasonable vision. So it was way out. And maybe it was way out because the variants weren't known. Now we can be more precise. And I think if you want to know, or maybe the parents want to know, if it's a child, then it is definitely much more precise. We can go in, there's whole data set saying, if you have this variant, this is the likely progression. Having said that, there are modifier genes that can help or not help. And I've seen this is one of the reasons I can't shy away. I've seen families where you have siblings affected, and the older sibling, who should be the worst, is actually better than some of the others. And that is because when you do the whole analysis, we study some families that they have some protector gene that seems to modify it. So there are genes that modify it. So it's not always an exact science, but and that is because there are all those other genes that may be helping. But certainly, if you want to know, we are much better equipped now to answer properly or as best as we can.
And this one's actually from me. So if that is the case, and when we are more aware generally how progression will happen, do lifestyle choices and things like not wearing sunglasses, all of those other things that are protective factors, do they come into that whole progression story as well?
It is terribly complex, and the whole vitamin A thing has been up and down. Does it help? Does it not help? Sunlight, it would make sense that you should try and protect your eyes, but I don't know if it's a very tricky thing to work out. And this is such a variable condition. I have done this study and on over 1,200 nuns in the island of Ireland, looking at AMD, and a lot of these ladies are very light protected because they don't go out much. And then there's the other end where they go off to the missionaries and they're out and ferocious. And you know what? I wasn't able to show any difference.
Oh,
and
wow.
even on on one disease which is very simple genetically compared to this, at the end of the day, and there's so many studies and they've never been conclusive. So I think an RP, it would make sense, but it's hard to be absolutely conclusive.
Right. Right, final advanced question that we have. Obviously, anyone who's tuned in, do please put your questions in the Q&A box. So the final one I have in advance is, I have recessive RP. Are there stem cell treatments for this yet?
Yeah, probably. I think they are lagging behind, and I don't think they would be specific for. I think if it worked, the stem cells, they would work pretty much for anything, you know, because you're replacing with healthy cells and healthy retina. So I don't think. I think the answer is no, probably, to that.
Here we go. We've got one online. It's just come in. So are there any developments or research into autosomal dominant RP?
Yeah, so it was the first gene ever discovered, as we heard this morning, and there is one trial. It's been a bit slow, and it is because, as this morning, I think it was one of the speakers this morning said, if you're recessive, you can replace the gene that's faulty with a normal gene, whereas in dominant RP, the gene that's there is doing too much, and what you have to do is knock it down or cut it out and then replace. But there is one for RP11 and the PRPF31 gene, and it's actually an RNA therapy that's being developed for the RP11. So we would have thought that would have been the first one, you know, because it's dominant, and but it is trickier to, you have to knock down or cut out and then replace. But there is one VP001 RNA therapy for our PRP31 gene, phase 1 to 2, and they're hoping to launch phase 2 to 3 in 25. So it must be going somewhere, yeah, but it's slow.
Somebody just asked a question online here about the gene agnostic trial, and that was at John Hopkins, wasn't it? Or I think you said earlier.
Yes.
So I've put, we will try to get more information in our next newsletter.
Yes.
I'm just popping an answer in on that. Okay.
Good.
Well, we've come to the end of all the questions we've got right now. I'm doing a shout out now to anybody who is online. If they have any questions still remaining, do let us know. Obviously, if we have no questions, then we'll finish up. If you do have questions after we finish for the day, then do please email them to info@retinauk.org.uk, and we'll do our very best to answer them directly to you. As I said previously, our research development manager, Kate Arkle, has a lot of knowledge and also reaches out to the professors and experts that we're in touch with for details for answers. So yeah, you can be sure that you'll get an answer. I'm getting no more questions coming through.
Can I say one more thing?
Yeah, of course you can.
Yeah. So under the gene agnostic, there is the OCU400, which we've talked about. There's also a thing called NAC attack, which is N-acetylcysteine. And it's in phase 3. And the nice thing about this is it probably wouldn't do any harm if it didn't do any good. Phase 3 trial underway to test oral antioxidants, an antioxidant called acetylcysteine, and its ability to slow progression of RP. So that is for any RP. And it says the mechanism is that it protects retinal cells from oxidative stress, which we know can contribute to degeneration of retinal cells. Study plans, so it mustn't be quite started, but plans to enroll approximately 438 patients across dozens of sites in North America and Europe. Actually, I wonder, is this the one that Professor Michaelides was trying to get off the ground?
Possibly, yeah.
This morning, and then he said, despite the delays, they're recruiting well. But that sounds terribly promising.
It does.
It's an antioxidant. At least, what is it? The Hippocratic Oath says, at least do no harm. You know,
yeah.
It may. So, but yeah, that was the other one that popped up under gene agnostic.
Okay. Well, thank you to everybody who has asked a question today. And like I said before, do please email us if anything else springs to mind. It's always the way that the question comes to you the minute that we close. I'd particularly like to thank Julie Silvestri for joining us today. It's really, really great to have you here, and thank you for answering all of the questions. And thank you to all of our online delegates today. I know that in person, we've had a very full room, but we've had a very full online as well. And we really appreciate you being here. We will be providing the recordings of all the sessions probably by the end of this week, all being well, or the week coming. And in a few moments, we're going to be sharing a short review survey. It's just come up on the screen. It's 3 very short questions with different facial expressions, so sort of smiley face, sad face, and those in between. Do please take the time to answer that if you can. We need to know if we're doing a good job or not, and we will always tailor our content to meet the needs of our community. There will be a more comprehensive survey included with the follow-up email, which you should receive within the next half an hour. And then following that, in hopefully a few days, we will be sending another email with a reminder about the survey, but also the recordings and where you can find them. So thank you again for joining us. I hope you've enjoyed the day. I certainly have. Thank you again to Julie, and goodbye. Thank you so much.
Thank you. And congratulations on your 50 years.
Yes.
Amazing. Thank you.
Thanks.